Thank you, Pankaj. I know that we are eagerly waiting for the lunch, but just little bit more. Then after, so the next session is the kidney injury. As you know, since morning we are studying about discussing about the sepsis and then shock. The kidney is the first organ which will be most likely affected. And for this, I would like to call our chairpersons, Dr. Chandrasekhar sir. Sir is the retired professor and the head of the Department of Anesthesiology, Osmania Medical College, and Dr. Keshi Mishra. And Keshi Mishra is the head of the Department Critical Care Medicine for Yashoda Hospital, Samajigura. Over to you, sir. Yeah, sir. Do you have a speaker list? Okay, so I would like. So for the first session, I would like to call Dr. Lakshmi Rani ma'am. So she will tell about the protecting renal perfusion region and the options.
Dr. Lakshmi is HOD Department of Critical Care at Care Hospital, Visakhapatnam, Andhra Pradesh. She is the past ICCM chairperson of Visakhapatnam branch, won the Best City Branch Non-Metro Award in 2023, member of editorial board in Critical Care and ICCM, IDCCM, CTCCM, IDCCM teacher and examiner. She is the faculty at many workshops, national and international. And with that, Madam, please continue with your talk. Thank you.
Hi, good afternoon, everyone. Firstly, I thank Critic organizers for having me here today. I know you're all waiting for lunch. That'll improve your splanchnic perfusion, but for a few minutes, I'm going to talk about renal perfusion and what are the reasons which hamper the renal perfusion and how could we optimize and prevent kidney injury. So we regularly see AKI and hampered renal perfusion in our ICUs, which could be because of acute illness or decompensation of chronic comorbid conditions. So before we go for the reasons and options, basic renal blood flow, basic things I'll talk in 2 minutes. The renal blood flow is about 20 to 25% of cardiac output, which makes up to 1.2 to 1.3 liters per minute, of which cortex gets up to 90% and outer medulla 8 to 9% and inner medulla only 1%. And we know GFR in a normal normotensive person is about 90 to 120 mils per minute per 1.73 meters square. So renal blood flow and GFR are auto-regulated between the map of 60 to 160 millimeter map and the renal perfusion pressure of 60 to 100. So this picture shows about the renal blood flow, and we all know that renal arteries rise from the descending aorta, and which branch and branch becomes afferent arterioles and glomerular capillaries. And after supplying over there, it becomes efferent system, uh, becomes a renal venous system, becomes renal vein, and go to inferior vena cava. So coming to renal perfusion is the blood flow that passes through the unit mass of renal tissue in a given time, expressed as mils per minute per gram. Normally it is about 400 mils per minute per 100 grams of kidneys. So we have our kidneys are about 300 grams in weight. So it comes to around 1.2 to 1.3 liters per minute. So the renal perfusion pressure, how do we calculate? We deduct intra-abdominal pressure and central venous pressure, which is same as renal venous pressure. We deduct this from MAP. So you get renal perfusion pressure. It's about 60 to 100 millimeters mercury. What is autoregulation of renal blood flow? It's a homeostatic mechanism to protect the kidneys from fluctuations in arterial pressure. So which happens by two mechanisms. One is the myogenic response. It's the stretch receptors in preglomerular afferent arterioles, which sends the changes in pressure, that's vasoconstriction or dilatation, and respond accordingly. And the other mechanism is tubuloglomerular feedback. So sodium chloride concentration is sensed by macula densa and acts by renin angiotensin aldosterone system. So this picture shows it's maintained constantly between 60 and 160 in normotensives, and it shifts to right in hypertensive patients. So this is showing renal blood flow and GFR. So it's going hand in hand like in the normal conditions. So what are the mechanisms which affect renal perfusion? So anything causing dehydration, hypovolemia, contracted intravascular volume, ischemia, hypoxia, fluid overload, raised intra-abdominal pressure leading to abdominal compartment syndrome, or renal congestion caused by vascular thrombus, emboli, or direct renal injury during surgeries, or capillary leakage syndrome because of various conditions and situations. There'll be increased capillary permeability and glycocalyx disruption and loss of intravascular volume. The risk factors for developing AKI, what we usually see in ICU is sepsis and other chronic conditions like hypertension, heart failure, elderly population, diabetic, major burns, liver failure, fluid overload, cardiac and vascular surgeries, and major emergency surgeries, and contrast media. So how do we protect renal perfusion in critically ill patients? So it's a primary prevention is early detection and treatment of acute illness. So early resuscitation with crystalloids. So we have a lot of studies about balanced solutions versus normal saline. And the latest one is the basic study in 2021, which shows like a no mortality benefit and no difference in length of stay, ICU length of stay, or requirement of RRT. When we use normal saline, we have to keep in mind about avoiding hyperchloremic acidosis. And about crystalloids and colloids, studies like safe trying albumin solutions, 4% albumin in safe study, and albio study, recent one, which has shown improvement in hemodynamic stability but no difference in mortality or length of stay or requirement of RRT. So, and Christmas study in 2012 shown starches are not should not be used in as resuscitation fluids, and avoid overload and check with the dynamic parameters and ultrasound guided fluid resuscitation, vasopressors when required, like after fluid resuscitation, or early use of vasopressors to maintain MAP of 65 to 70. And in heart failure conditions, use of dobutamine or levosmendan. There's a drug called phenol-dopam, that's a dopamine 1 agonist, which is supposed to increase the renal blood flow but hasn't shown any benefit in using critically ill patients. And try to avoid nephrotoxic drugs as much as possible, wherever possible. And when you have to use, adjust the dosing intervals and consider PKPD of antibiotics. Maintain euglycemia, and secondary prevention is preventing nosocomial infections. So coming to few situations where we usually see AKI. So sepsis is the most common thing what we see in critically ill patients. Up to 50% develop AKI. Hypoperfusion is the most common cause causing AKI. So the causes can be multifactorial, the etiology: hypertension, ischemia, endothelial cell dysfunction, glycocalyx disruption, microcirculatory dysfunction. All these cause uh, reduced renal perfusion. So even after resuscitation, we improve cardiac output, but that may cause renal hyperemia, intrarenal blood flow maldistribution, which can lead to localized ischemia and hypoxia. So there's a study seen like norepinephrine may exacerbate septic acute kidney injury. So in this it says uh, norepinephrine increases renal blood flow, GFR, increases sodium delivery into medullary tubules, increases sodium absorption, reabsorption, which actually requires oxygen. So therefore, medullary perfusion and oxygen is reduced, which contribute to AKI. There are studies comparing noradrenaline vasopressin uh, in sepsis induced AKI. I think if it started in vast study and all is shown, if it started early in sepsis, they may be better, um, like it may be better choice using vasopressin if you use early, but it needs further studies. And heart failure, when it's decompensated, causes gives AKI. And heart failure in escape trial, didn't find any correlation between AKI, cardiac and cardiac index or SVR. So decompensation should be prevented, avoiding anemia and water and electrolyte disturbances, arrhythmias, and thus prevent AKI. And try to avoid nephrotoxic drugs, and loop diuretics may exacerbate kidney dysfunction, so it should be used for short duration. And mineralocorticoid receptor antagonist may be a better option in long term. And for in heart failure with reduced ejection fraction, to maintain renal perfusion, maybe need to have assist devices and implantable cardioverter defibrillators or cardiac resynchronization therapies or assist devices. And as a bridge therapy for these, or in transplant situations, may have to go for VA ECMO. And periop renal protection, and during anesthesia, GFR and urine output passively depend on MAP. So it's important to maintain MAP and avoid fluid overload, and which may cause intra-abdominal hypertension. They'll be less than, GFR is reduced even up to less than 25% if the intra-abdominal pressure goes above 20 millimeters mercury, because it compresses renal vessels and renal vascular resistance is increased, leading to in this hormonal changes, upregulation RAS, and which further increases sodium and water retention and becomes a vicious circle. So perioperatively, it's important to maintain adequate vascular volume and hemodynamic optimization, avoid overload, and precautions with nephrotoxic drugs, avoid hypoxia and hypotension. So it says like if you have less than 60 millimeters mercury, systolic BP for 20 minutes, or less than 55, less for about 10 minutes, it will increase the risk of AKI. So thinking about anesthetic agents like propofol in ICUs, we use propofol infusion. So you have to keep in mind about propofol infusion syndrome, with, where you get the severe metabolic acidosis or rhabdomyolysis and AKI. So Dexmed will increase the renal perfusion, but you have to think about hemodynamic stability. So abdominal hypertension, you have to treat it immediately with deresuscitation diuretics or decompression. So in thoracoabdominal surgeries, the main cause of AKI is hemorrhage and hypovolemia. So maintain the map with replacement with blood and blood products and fluids, and minimize aortic cross clamp time. And you have to think about possibility of intravascular hemolysis and myoglobinemia, which need to be addressed. And there are some techniques: distal aortic perfusion with left heart bypass or partial cardiopulmonary bypass, and there's selective renal perfusion. These things are used to maintain renal perfusion. And this is the ischemia reperfusion, where all the inflammatory mediators, oxygen free radicals are produced, and inducive nitric oxide is produced, which causes damage to the kidney perfusion. And in liver failure, it's mainly HRS, AKI, where you need to treat with an albumin terlipressin, and UGI bleed is a common cause for hypovolemia leading to AKI. And in tubular deposits like rhabdomyolysis, TLS, and these medications, where you need to treat early hydration, urinary alkalinization, and renal replacement to reduce potassium and myoglobin levels in blood. So contrast nephropathy causes, where the contrast cause vasoconstriction and impair autoregulatory function. Need to do proper hydration pre and post contrast, and use hypo or isotonic contrast, and a low volume as possible should be used, and should not be more than 2 times of baseline GFR. So N-acetylcysteine for 48 hours starting before using the contrast is helpful, as it is antioxidant and anti-inflammatory. So withhold the other nephrotoxins concomitantly. In emergency situations, use urinary alkalinization. There are some recommendations by ESICM working group for prevention of AKI. Most of the grade 1 recommendations are for not using dopamine, not using starches. So against are the mainly grade 1 recommendations. Other recommendations are fluid resuscitation with preventing overload, and use against use of starches, and using isotonic crystalloids.
Ma'am, you're like
Yeah,
overshooting the time, ma'am.
yeah.
Can you just conclude?
Almost done. So monitor chloride levels, and albumin when it is necessary in treatment of septic shock. It's 2C recommendation. It's only suggestion. So titrate vasopressors to get the map of 65 to 70 rather than going to higher side. But in hypertensives, go for higher map like 80 to 85. So mainly like all other recommendations are grade 2 and 1B, like Norepinephrine is the first line to use a vasopressor. So I already said about dopamine. So diuretics only for a short time, and they should not be used solely to prevent AKI. So you have to think about the problems with the sedatives when you're using. So metabolic interventions like N-acetylcysteine, it's only 2B recommendation suggestion, should not be used in septic shock cases. It may give adverse problems. So statins should not be used in perioperative use to prevent post-op AKI in cardiac surgeries.
Sorry, ma'am.
So
Can you just
use the
conclude, ma'am?
bundles. So mainly like the conclusion is maintain hydration, maintain MAP, use early vasopressors. Still first line is norepinephrine. Don't use dopamine. Don't use starches. And all other things are need still some more evidence to put them as recommendations. Thank you.
Thank you. We'll, because of paucity of time, we'll move to the next.